the 7th of November, and it's 14:31. Today we're going to have our topic, which is STI management and care. And we're lucky to be joined by Dr. Owen Ngalamika, who's a consultant dermatovenerologist with multiple publications in cancer research, immunology, and genetics. So our first presentation, our didactic presentation, is going to be by him. Then we're going to have a Q&A session and discussion. And then after that, we're going to have a case presentation by Mr. Brian Lenge from Yeta District Hospital in Sesheke. Mr. Brian, are you with us? Mr. Brian? Okay, I'm sure Mr. Lenge will join us soon. And then we'll go into our expert discussion. So once again, please don't forget to register. The link is provided in the chat box below. And then some house rules. So let's make sure we mute our microphones during the presentation as to avoid disturbance during the presentation. Let's raise our hands for questions, and then we shall tackle these at the end of the presentations. So let's use this time to echo out today's topic. I'll share the presentation. Is this one? Okay. So over to you, Dr. Ngalamika. Thank you for joining us today.
All right. Thank you very much for this opportunity to come and present. I can move the slides. Okay. All right. So we're looking at STI management and care. The objectives will be to review epidemiology, including trends of STIs globally and also in the region, and also look at clinical presentations for the most common STIs and how best we can prevent STIs. So we'll cover some of the most common STIs that we see, not each and every STI. There are some that are pretty rare. So I think the focus will be on the common ones. And then also discuss screening, when to screen, what to screen for, and then also diagnosis and management of the common STIs. So these are some of the STIs that were picked up: herpes, syphilis, gonorrhea, chlamydia, trichomonasis, genital warts, molluscum. Hepatitis B and HIV are usually covered under the most of the HIV programs. We're not going to go into that in detail, but we'll also look at some of the complications that come about from STIs. And next slide. So in terms of epidemiology and trends of STIs, so in 2021, WHO estimated about 1 million people, that 1 million people acquired an STIs daily globally. And there was an estimated 376 incident cases of these 4 STIs, chlamydia, gonorrhea, and trichomonasis that cause genital discharge, and then syphilis in people aged 15 to 49 years over a period of time from 2009 to 2016, and that an estimated 417 million people were infected with HSV at any given point in time. And then also about 291 million women infected with were infected with HPV at any given point. And of course, more recently, data suggests that cases of genital ulcers in sub-Saharan Africa are mostly due to herpes simplex virus, mainly type 2, and not syphilis. Way back in time, syphilis was the most common cause of genital ulcers. Also, like we've observed from a recent study that was conducted in Zambia, that 70 to 90% of all the genital discharges were due to mainly chlamydia and gonorrhea. And also, it's been observed that, gonorrhea, there is a change in drug accessibility patterns for gonorrhea over the past few years. So gonorrhea is one of those STIs that become resistant to almost anything over time. So as regards to Zambia, so gonorrhea is the most common STI, I've just said. So among males, it accounts for 70%, and females 64% of the genital discharges. A recent study also found multiple non-gonococcal urethritis, like ureaplasma erythecum, that would cause a urethritis or cellulitis. HSV2 was the most common agent that caused genital ulcers. From this study, about 41% of all genital ulcers had HSV. And then syphilis was detected among 6% of the ulcers, which means the HSV is the most common cause of the ulcerations. Also, within UTH, we observed that about 70 to 80% of individuals presenting with STIs at the skin and STI clinic have genital warts. Next slide. So the epidemiology of STIs in Zambia. So this is the proportion of STIs among OPD attendees over a 4-year period, 5-year. Yeah, so it shows that there is an gradual increase in the proportion of STIs among individuals attending OPD clinics countrywide.
Okay, thank you, Dr. Ngalamika. Quite interesting statistics, which brings us to our first poll question, which reads, which of the following STIs is prone to drug resistance? I repeat, which of the following STIs is prone to drug resistance? And we have A, Neisseria gonorrhea, B, C, trachomatis, C, human papilloma virus, D, treponema pallidum. Which of the following STIs is prone to drug resistance? A, gonorrhea, B, C, trachomatis, C, human papilloma virus, and D, treponema pallidum. Okay. Okay, so we've got a good response of option A, and we'll see how this goes along the presentation. Okay. We have our second poll question, which reads, genital ulcers resulting from STIs are mainly caused by which agent? And the options are A, human papilloma virus, B, herpes simplex virus, C, treponema pallidum, and D, Haemophilus ducreyi. So genital ulcers resulting from STIs are mainly caused by which agent? Option A, human papilloma virus, B, herpes simplex virus type 2, C, treponema pallidum, and D, Haemophilus ducreyi. Okay, so again, we've got interesting results with 57% that have gone for HSV type 2 and 30% that have chosen treponema pallidum. And once again, we'll learn more about this in the next few slides to come. And we have one more poll question after this, which is, which antibiotic is currently suitable for treating gonorrhea in Zambia? And we have A, ciprofloxacin, B, cloxacillin, C, ceftriaxone, and D, acyclovir. Which antibiotic is currently suitable for treating gonorrhea in Zambia? A, ciprofloxacin, B, cloxacillin, C, ceftriaxone, and D, acyclovir. Okay, quite an interesting response, Dr. Ngalamika. We have 55% that have chosen ciprofloxacin and 43% that have gone for ceftriaxone. Back to you, Dr. Ngalamika.
Okay, so before we go into I think there's a slide missing in terms of the approach to STI management. I'll go into the specifics after that. So usually there are three approaches. So there's a syndromic management of STIs. There's the etiological and the clinical. Syndromic, usually in a setting, maybe a remote setting with no laboratory support. If one presents with a discharge, for instance, you cover the different agents that can cause that discharge. So you cover the agents that can cause that syndrome. With the etiological is the evidence-based. So if one has a discharge, you do all the lab tests. You find chlamydia, you treat it. You find gonorrhea, you find something else, you treat it. Clinical, usually a combination of etiological and clinical, but it's based on experience. So if you see like this type of discharge, for instance, has a certain color or odor, then you treat according from your experience, what is the likely agent that can cause that. So these are depending on the setting where you are and the experience that you have, you may decide upon what to use. So herpes simplex or genital herpes is caused by human herpes simplex virus type 2. Type 1 can also cause genital herpes, but it usually causes the common cold sores. So there are these sores that occur in the, herpes labialis, they be associated with a headache. So it usually causes that, but in terms of an STI causing an ulcer, it's usually herpes simplex virus type 2. So it will present as multiple painful group vesicles on an erythematous base. So if you look at this picture here, you can see the multiple those were like vesicles, like fluid-filled lesions, but they break down and then you have this open area, which is like more of an erosion. And if you look closely, you find that there is grouping in terms of where the lesions are occurring. And then the base is erythematous. If you see the pinkish area there, it's erythema, but you can distinguish it from the brownish normal skin around. So sometimes you can see the intact vesicles, at times you only see the broken ones. So usually treatment, so there's no cure for HSV. When one gets exposed to it, like other human papillomaviruses, it remains in the body for life, and due to certain triggers, it can, once in a while, someone may have the eruptions. So ideally, treatment is suppressive and symptomatic. So there is no need to treat one who was exposed but doesn't have the lesions. And there are multiple antiviral agents that you can use to treat. The commonly available, of course, is acyclovir. If you have that, it can easily at least reduce the duration of symptoms if the eruption has already occurred. Next slide. Syphilis also falls under the STIs that cause an ulceration. It's caused by the spirochete Treponema pallidum. Clinical features, so syphilis, you group it into early and late syphilis. Under the early syphilis, when one acquires syphilis over the first 1 year period, they may present with a primary syphilis, which will be a primary chancre or ulcer, which is usually an indurated and painless ulceration. So it's usually indurated and painless. You can distinguish it from herpes ulcer, because herpes, there'll be multiple grouped ulcers and they'll usually be painful. But for syphilis, it won't be painful. So the top picture there just shows a chancre. And secondary syphilis, so primary syphilis will heal on its own without treatment. Later, a few months later, one may present with secondary syphilis, which may be in many manifestations, such as a maculopapular rash, which is usually asymptomatic, not painful or itchy. And then they may also have some generalized lymphadenopathy. They may have alopecia, a certain type of moth-eaten alopecia, like an insect has been chewing on the hair. And then they may also present with these patches on the genital areas or other, areas which are known as condyloma lata. Tertiary syphilis, so one may will recover from secondary syphilis without treatment, and then they'll go in the latency phase. So they will be in latency, and later on, after even 20, 30 years, shorter or longer, they may present with tertiary syphilis, which may present as neurosyphilis with different neurological manifestations, cardiovascular syphilis, which can present as an aortitis or other cardiovascular manifestations, and also cutaneous manifestations with some certain type of granulomatous formation on the skin and also in the bones, known as gumas. Lab tests for syphilis, so you have the non-treponema test, which is RPR and VDRL. I know we usually do these tests. So these are non-treponema because they are not specific for syphilis. So these RPR can be positive in someone who is pregnant, someone who, they have malaria or other autoimmune condition. So a positive RPR does not equal syphilis. So it can also do an RPR titer. So at least it will tell you the stage. Also, the titer is important for monitoring treatments to syphilis, because you can keep detecting the tests, they would keep on coming positive and yet someone was treated. So what will guide is the titration. Then treponema tests, we have TPHA or TPPA can be available, and there are other treponema tests as well. So these are specific for antigens on the treponema pallidum. So it's very specific for syphilis, very important to confirm syphilis. But the thing is, the treponema test will remain positive for life. So if someone was treated before, they may still have a positive TPHA, and they may still have a detectable RPR. So the titer also. So you need to put all these things together. So in terms of treatment, there's penicillin, but you also have crystalline penicillin for other manifestations as well. If you look at the picture there, at the bottom is the secondary syphilis with some manifestation of keratoderma bladnorrhegicum. So it's quite common in syphilis. So these are hard areas in the palms and the soles. Next. Gonorrhea, of course, that picture doesn't look very nice, but so gonorrhea is caused by Neisseria gonorrhea. It has an incubation period of about 3 to 6 days. Presents with a purulent or mucopurulent urethral discharge. You see the urethral discharge in males. Then there'll also be dysuria. But up to about 50% of women with gonorrhea may be asymptomatic, which is a serious problem because it can lead to complications, including sterility. So lab tests for gonorrhea can do a microscopy, can do a gram stain where you see the gram-negative diplococci. And then you can also do antigen tests, which are point-of-care tests, but the gold standard will be culture sensitivity. Gonorrhea is very prone to mutations that can make it become drug resistant. So there's always been a change in trend of antibiotics that have been used over time for gonorrhea. Then there's also nucleic acid amplification test, which is some kind of PCR method that is used to test. Treatment, you can give a third generation cephalosporin. Usually ceftriaxone is widely available, but there's also oral cefixime, other third generation cephalosporin, but mainly ceftriaxone, cefixime. It often develops drug resistance, as I've said. But as you treat gonorrhea, it's always good to treat for chlamydia as well, because there usually be a co-infection, or it can be one or the other. The discharge may not tear apart, or sometimes one may have both organisms. Next slide. Chlamydia is caused by Chlamydia trachomatis. So clinical features pretty much similar to gonorrhea, but we have dysuria, urethral discharge, frequency, pyuria, and agency, and then they'll have the prurient or mucopurulent urethral discharge, like we saw in the previous slide. And then there could be a reactive arthritis, which is a complication of gonorrhea, where one can present with a triad of arthritis, urethritis, and uveitis. Cervicitis in females is mostly asymptomatic, the presentation, like in gonorrhea. So the chlamydia will be asymptomatic, or one may have mild, unnoticeable discharge. They may have dysuria as well, and then they may have the mucopurulent cervical discharge and postcoital and intermenstrual bleeding. It's very important to note that if you're going to swab for either gonorrhea or chlamydia in a female, you need to get an endocervical swab, because it will not infect the stratified epithelium, to infect the cuboid or columnar epithelium, the endocervix. So the lab test for chlamydia is hard to grow in culture, so you can do nucleic acid amplification tests. At least for chlamydia, is quite sensitive to the tetracyclines, like doxycycline can be given for a week, but also concurrently treat for gonorrhea with ceftriaxone and or other third generation cephalosporin. The next slide. Trichomonasis is caused by the protozoa Trichomonas vaginalis. The clinical features are a diffuse white or clear, typical, a frothy kind of malodorous or yellowish green discharge. Then there could be severe itching in the genital area with vulvar like irritation, and then there can be urethral irritation. So trichomonasis can infect both the vagina and then the endocervix as well. But so if you find an infection just affecting the vagina and not affecting the cervix, then you know like it's likely to be trichomonasis. Lab tests, you can do a wet mount microscopy where you see the motile protozoa. You can actually see it moving on the slide. And then you can also do rapid antigen detection tests. Treatment, metronidazole 2 gram, the oral stat. There's also an extended regimen where you can give for a few days, but a lesser dose and maybe twice a day. Genital warts are also very common. So they're caused by human papillomavirus. They may be more extensive in, like HIV immunosuppressed individuals. Clinical features will include indurated or keratotic like hardish, flesh-colored or gray growth, like that you see on the picture there. They may have multiple finger-like projections, or can be smooth. So like you can see the cauliflower-like, growths there on the picture. Treatment, you can use podophyllene, cryotherapy where we freeze the growth. Salicylic acid is a keratolytic agent that can also clear it, and then can also cauterize or remove them, find ways of, there are different methods that can be used to deal with them. Or imiquimod can be applied. Imiquimod is like kind of stimulates an immune response against the virus, which human papillomavirus, and hence that leads to resolution of the lesions. Molluscum contagiosum can also cause growths in the genital area, but as caused by Molluscum contagiosum virus, So it can also be found in children, but it's usually just, close physical contacts. So they'll have it in the face, other parts of the body, just from contact. But otherwise, if it occurs in adults, the transmission is mainly through sexual contact. And it may be more extensive in suppressed individuals. The clinical features will be a dome-shaped, firm, rounded papules, which may be pink or skin-colored, with the central umbilication. And then if you poke it, there's a caseous material may be expressed. So if you see those pictures there, you can see the dome shape, but then there's a central umbilication there. That's very typical of molluscum. So the whitish material that comes from it is quite, it's quite infectious. There's so much of a virus in there. So if you're going to poke that, you need to take caution. Treatment, curettage, cryotherapy, freezing the lesion, can use podophyllene and imiquimod like discussed for warts. Some of the complications of STIs in males can ascend and cause inflammation in the epididymis or the testis. Long-term, if no poor treatment, can cause urethral strictures, sterility. Fistulas can form depending on where the infection is, and then there's buboes. Like in syphilis, there's these inguinal lymph nodes that may be affected, or other types of STIs may also cause that. And there can also be an arthritis. For instance, chlamydia can cause this the Reuters syndrome. Then the prostate may also, the infection can also ascend to the prostate. Females, I have the common PID, chronic lower abdominal pain, sterility, buboes, lymphedema, because when the lymph nodes are affected, there is blockage of lymphatics, can cause a woody heart edema. Then fistulas can also occur, and then ectopic pregnancies and miscarriages as well. In terms of screening, so partners of individuals diagnosed with chlamydia, gonorrhea, trichomonasis, syphilis, hepatitis B, and HIV should be screened for STIs. Of course, other STIs as well, you can still screen, but these should be screened with the intention to treat those that are affected. Asymptomatic females of male partners treated for chlamydia and gonorrhea should be treated regardless of their lab result because of the long-term consequences of these, and also the issue of these infections being very silent in females. Sexually active individuals should undergo screening for syphilis and hepatitis B. So if on a routine basis you wanted to just screen individuals who are sexually active, you would screen, of course, HIV as well. And then syphilis, because syphilis can remain silent. Someone may acquire the infection, but they will never have any symptom. So they may live with it until it presents as a neurosyphilis or tertiary syphilis. So, and then hepatitis B, the consequences are known, liver cancer and other things. Of course, it's good that there is a vaccine for hepatitis B, but not so many people are vaccinated. Okay, so in terms of the key points, so STIs are very common among patients presenting in OPDs. We've seen the figure that I showed previously in terms of the trend slightly going up slowly over time. And then RPR is not specific for syphilis, so it should be coupled with a triple test if possible. So many conditions, pregnancy, old age, malaria, all these can lead to a positive RPR. So one can be over-treated with benzathine, and yet they don't even have syphilis. HSV2 is the most common cause of genital ulcers. Of course, there are other causes, but herpes simplex virus is the most common cause. If you see, it will usually begin with, some itching or some pain in the area before even the eruption. So a good history. And when you examine, you see multiple grouped either ulcers or vesicles. You can, have an idea that, okay, this should be herpes and treat accordingly. Culture and sensitivity of Neisseria gonorrhea is very necessary if available. Gonorrhea develops resistance over time. So it's always good to perform culture and sensitivity from time to time if you have the means to do that.
Okay, thank you so much, Dr. Ngalamika. That was a very lovely presentation. So many key points, so much knowledge from this presentation that I'm sure most of us have picked up. At this point of time, I'd like to open up to questions for Dr. Ngalamika. Okay, so Dr. Ngalamika, we've got a few questions in the chat box. This is from Sondo Geoffrey. How available is RPA titers in health facilities? And then there's another question, is the treponema test available in hospitals or rural health facilities?
Okay, so I suppose, what's the question?
Sorry. Sorry. Before we jump into the questions, we'll just go through a re-poll. Is it re-poll just to check how much we've learned so far. So, which brings us back to our question 1. In which of the following STIs is prone to drug resistance? A, Neisseria gonorrhea, B, chlamydia trachomatis, C, human papillomavirus, and D, treponema pallidum. Which of the following STIs is prone to drug resistance? A, Neisseria gonorrhea, B, C, trachomatis, C, human papillomavirus, and D, treponema pallidum. Okay. So I think some learning has happened, Dr. Ngalamika. We've got 89% who've gone for Neisseria gonorrhea. Your comment?
Oh, yes. Yes, at least there's an improvement from the initial poll. Yes, so Neisseria gonorrhea is the one that develops resistance over time. Previously, and I think that's going to come next but previously there was pectinomycin, then ciprofloxacin, then now it's the 3rd generation cephalosporins that is sensitive to. So chlamydia trachomatis is quite stable, so it's good with macrolides or tetracyclines. And HPV, that's another story. And yes, so it's Neisseria gonorrhea.
Okay, great. Okay, which brings us to our second poll question. Genital ulcers resulting from STIs are mainly caused by which agent? A, human papillomavirus, B, herpes simplex virus type 2, C, treponema pallidum, and D, Haemophilus ducreyi. Genital ulcers resulting from STIs are mainly caused by which agent? A, human papillomavirus, B, herpes simplex virus type 2, C, treponema pallidum, and D, Haemophilus ducreyi. Okay. And once again, we've got 78% who've chosen human simplex virus type 2, followed by 15% who've chosen treponema pallidum. Dr. Ngalamika, your...
So again, yeah, the majority wins or rules. So it's HSV2. Human papillomavirus doesn't cause ulcerations, causes a growth, a bump, like we saw on the one of the last slides on genital warts. So HSV2, it was between HSV2 and treponema pallidum for syphilis. So herpes simplex is the most common cause for genital ulcers currently.
Great.
Yeah.
Thank you. Which brings us to our last poll question, which reads, which antibiotic is currently suitable for treating gonorrhea in Zambia? I'm sure we'll get 100% over here. We have A, ciprofloxacin, B, cloxacillin, C, ceftriaxone, and D, acyclovir. Which antibiotic is currently suitable for treating gonorrhea in Zambia? A, ciprofloxacin, B, cloxacillin, C, ceftriaxone, and D, acyclovir. Okay. Again, so we have majority 73% that have gone for ceftriaxone, to third generation cephalosporin, and then we've got ciprofloxacin at 26%.
So it's ceftriaxone. Currently, I think has very high sensitivity for gonorrhea. So cipro previously, but currently it has shifted. So the sensitivity pattern. So most of the strains are not very responsive to ciprofloxacin currently.
Okay, all right. Thank you, Dr. Ngalamika. So at this point of time, we can take a few questions. So you can kindly raise your hands or ask questions in the chat box. So we had, initially we had a question about how available RPR titers are in health facilities. And then also, we have a question of what is the difference clinically between trichomonas and candidiasis?
Okay. RPR is it's quite available, I think, at the maybe at district level facility. So like I said, the approach to management depends on what you have. So if you have you have treated and you think you treated for syphilis based on the clinical presentation, based on your history and clinical findings, and you were confident of having treated syphilis at a certain facility, and then the patient still keeps coming up, then you can send them to a higher level. But like I mentioned, RPR titer is very important for monitoring response to treatment. So expect like a 4-4 drop over a period of 3 to 6 months from the time that you gave your treatment. So it will be good to do the titer at the beginning, because you may be having an RPR positive for 2 years, and then or 3-5 years, you keep on treating the patient. So I don't know about availability in terms of the rural health, but I think at the district level, I think it would be good to, especially someone you suspect really should to have syphilis, to send a sample there and they do the titer for you. Then the next one was about differentiating between candidiasis and trichomonas. So candidiasis is a loose kind of, trichomonas is a loose kind of discharge. It can be frothy, greenish, and also it has a very malodor, like fishy kind of smell. It's different, the discharge from candidiasis, which is, so candidiasis is not considered an STI to begin with. So candidiasis is usually, the discharge will be curdy, like cheesy-like. Otherwise, the other one will be a cheesy-like whitish discharge. Or about trichomonas, it will be frothy, greenish yellow, and very loose-like.
Okay.
Yeah.
Thank you, Dr. Ngalamika. So we've got a number of questions again. Why is it that syphilis positive is treated with benzathine penicillin 2.4 mega units weekly? And then there's some literature that recommends a single dose of benzathine penicillin. Is it adequate? And then we have a question, how long does it take for an RPR to stop testing positive after completing treatment?
Okay, so in terms of weekly things, so the most ideal, if you have established the time when one got infected, for instance, you speculate that they are in the early syphilis is, like 1 to 2 years, 1 year, depending on, which guideline you're using. So in the first 1 to 2 years, if they have early syphilis, for instance, primary, secondary, or early latent, 1 dose of benzathine penicillin is sufficient. But if you see the patient more than 1 year since they acquired the syphilis, then you need to give the 3 weekly doses. So give 1 dose a week later for 3 doses. So that's the recommendation. So otherwise, 1 dose is sufficient for early syphilis, syphilis acquired in the last 1 year. So benzathine penicillin has a very low half-life, which should be enough. The dose is enough to clear the syphilis with just 1 jab, if it's early syphilis. Then in terms of RPR positivity, I can't really say. It can take months or even years. And then because RPR, the positivity can be due to other things as well. So you can't really establish whether it's due to the syphilis or other things. That's why it's very important to confirm. When you confirm, if the titer drops, maybe what you are detecting is due to, another condition which the patient has and not syphilis. Also, really, it can be months or even years. Yeah.
Okay, thank you. We've been joined today by Kapanda Mini Hospital, and they've asked a question: when can RPR tests become negative? Which I think Dr. Ngalamika has explained very well. And then the second one is, what should be done for a wife who had RPR negative today, but with genital itchiness, while the husband's RPR was reactive today and has genital ulcers?
So let's say the husband is RPR positive with symptoms that are suggestive of syphilis. So you confirm, if you can, with the treponema test, then you do the titration and begin the treatment for the husband. Then syphilis, there's no urgency in treating. You can still repeat the test for the wife later. And then if they are positive, but also it depends on I think it really depends on your judgment. The husband may be positive. When did he become positive? Is there a risk that he transmitted to the wife? So there are a lot of things that you can put in consideration. If there is, and the wife is willing to just be treated, you can treat. But if not, you can repeat the syphilis test at a later time. Seroconversion will be like 21. The incubation period is about 3 to 21 days, so maybe within a month. So all those parameters you can use to make your judgment.
Okay.
Yeah.
Thank you. And this last question that we'll take before we move on to the next presentation is that, are we still giving antibiotics for 2 weeks for urethritis or PID empirically in areas which MCS is not possible? And then, has there been sensitization on ceftriaxone used for gonorrhea in view of resistance to ciprofloxacin? And what is being used in rural and small facilities that may not have access to ceftriaxone?
I suppose ceftriaxone should be available in most of the facilities. So the new STI guidelines should be out soon. So I think that after the guidelines are out, there's usually some training, and I think people will be informed on the changes in terms of treatments and medicines. Usually it's the gonorrhea. If there's a change in guidelines, it's gonorrhea that you see a huge step in terms of a huge change. It's good if it will maintain. I think there's some studies somewhere they're trying to bring up a gonorrhea vaccine, which will be very important, that will contain the virus and prevent. But I think after the guidelines are out, then I think there should be sensitizations. There's a study that was done. I wasn't part of the study. I don't know how much they did in terms of sensitization, but I think they had given a few talks at some meetings in terms of what patterns are there with regard to gonorrhea.
Okay, thank you so much, Dr. Ngalamika, for the presentation. I'm sure we've learned a lot. So next we're going to jump into a case presentation. So we've got, we'll take one last question from Mwape Sibuanta. You may ask your question. Mwape Sibuanta. Or Chileleko Mapiki, you have your hand up. You can ask a question.
I have a question. I would love to hear the doctor's comment on two things. In most cases, you find that the men will have plurulent male urethral discharge coming to the clinic, but the woman will have no symptoms. And you find that maybe many guys from the same community, they say when they went to that girl, they came with the same symptoms of plurulent male urethral discharge, which in a case like ours, where we do not have sufficient capacity to check for gonorrhea, we go and treat empirically for that. So why is it that males would develop those symptoms 2 to 3 days later after having sex with that woman, but the woman will have no symptoms for a longer time? What would be the explanation? And then I would love to hear the doctor's comment on using triple therapy, where people use doxil, cyprobid, and metronidazole in treating of such kind of STIs. What would your comment be on that one? Thank you.
Okay, so in terms of asymptomatic in females and symptomatic in males, it's mainly due to anatomy. So you have the male, the urethra is out there. For the females, it's an endocervical infection with the cuboidal column, and the females also have the natural discharge as well. So that can mask the discharge from gonorrhea. So it's just mainly due to the anatomy. So a male gets infected to be right in the urethra. It's easy, the discharge will be easily expressed. They'll feel pain on urine. The male transmits to the cervix. The cervix in the vagina also, there's other discharge, like, this, so that can mask. That's how females have less symptoms or no symptoms compared to males. In terms of triple therapy, so this is the syndromic approach. I mentioned to say that depending on where you are, if you're in an area where you can't do the lab tests, culture sensitivity and everything, and then you have these discharges, because you can't wait, there will be keep-on transmissions and also the long-term complications of untreated. So you need to make a judgment. You need to treat. But when you give the triple therapy, you're trying to cover all the organisms that cause a discharge. For instance, chlamydia, gonorrhea, and trichomonas. So that's how you approach it, because you don't know what exactly, you haven't done the lab test. So you treat everything and then hopefully hit something.
All right, thank you so much, Dr. Ngalamika. We'll move into the case presentation now by Mr. Brian Lunenge from Yeta District Hospital. Mr. Lunenge, are you ready? Is it this one? Okay. Mr. Brian Lunenge. Yes.
Good afternoon, Doc.
Good afternoon, thank you. Can we share your presentation?
Yes, this is a.
Okay, you can
All
go
right.
ahead.
Good afternoon, network.
Good afternoon, thank you.
Yes, please. This is the Shoma, the mentor from Sesheke. Unfortunately, Mr. Brian is held up somewhere, so we are presenting this case on his behalf.
Thank you. You may go ahead, sir.
So okay, yes, sir. So the history is this of a female 30 years who came to the facility with the complaints of headache for 3 weeks, sexual swelling for 3 weeks, loss of appetite for 3 weeks. The past medical history of this client had hypertension, then the HIV status wasn't known, no epilepsy, no asthma, but the patient was anemic. Then the past drug history was that of a patient had received folic acid, ferrous phosphate, nifedipine, and diuretic. And status, this is a council worker who's not married but has got a man friend, doesn't smoke and doesn't take alcohol. On physical examination, which was done on the 12th of September 2022, general condition was stable. Though she had a puffy face with some mild pallor, the VE wasn't done. Patient wasn't comfortable to undergo the same. Then the CNS, we had no abnormalities discovered. On the CVS, S1 and S2 was normal. The gastrointestinal tract, respiratory tract, and the GUT, all these were normal. The skin was okay, and the vitals were temp 38 degrees centigrade with a body weight of 50 kgs. Her blood pressure was 170/105 millimeters of mercury with a pulse of 100 beats per minute. The management which this client received was, she received the ceftriaxone 2 grams, benzocaine penicillin 2.4 mega units weekly for 3 weeks, received folic acid, ferrous sulfate, nifedipine, and diuretic. On this day, the 12th, the tests which were conducted were RPR, which came out positive. The liver function tests were not done because we had no reagents. The HIV was done, but it came out positive. But you realize that this was the diagnostic counseling test in which the provider initiated. The client had declined to have an HIV test. The gram index was done and it was negative. Viral load wasn't done as baseline. And the full blood count was HB 7 grams per deciliter. The WBCs and the RBCs were not done. The questions which the clinicians and the hospital had are as follows. The first one is, in the absence of signs and symptoms of STI, how best can we maximize screening and treating of STIs in our facilities? Number two, how best can we do index STI screening in clients who refuse to disclose their STI status to their sexual partners? Number three, how best can we manage this client who has refused to test for HIV, but DCT HIV positive was done, and we confirmed the positivity of the result? So the three questions are the ones which the facility wants help from the network. Thank you.
Thank you so much, Yeta District Hospital. At this point of time, I'm going to ask the network for any clarifying questions to our presenter before we can go into the expert discussion. So we have one question in the chat box. Looking at the presenting complaints, what prompted the team to want to do a VE? Mr. Francis, would you like to take up this question, please? Looking at the presenting complaint, what prompted the team to do a VE?
Sorry, are you able to get me?
We can get you now, yes.
Okay. I'm saying the issue of the VE came in after the facility realized that the RPR was positive. So they wanted to examine the clients to see if there was any genital ulcers. Thank you.
All right, thank you. And then was a urinalysis done?
Unfortunately, the urinalysis wasn't done because the facility had no sticks by that time.
All right, thank you. Any other questions from the network? Yes, Dr. Chanda, you may go ahead with your question, sir.
Thank you very much. Thank you for the presentation. I might probably also raise some of the questions like how we ended up to go at the STI pathway. When this patient is presenting with someone who thinks it's in the space of cardiac or renal. I know that's besides the point. But my question is, why was the patient treated with ceftriaxone and penicillin at the same time? And I think I do see quite a lot of this, but I just want to understand from that end why they thought in that pathway.
Thank you, Dr. Chanda. Mr. Francis, so the question was, why was that choice of antibiotics made?
From the clinician who was attending to the client, the history we received was that the combination of the two, he was trying to treat the syphilis using the benzathine, and at the same time, he thought that he could cover the client on the ceftriaxone, bearing in mind that maybe the client could have some gonorrhea, though this client never presented with any vaginal discharge. So that was the explanation we got from him when we tried to interact with him.
All right, thank you. Sumbwanyambe, you may ask your question. Sumbwanyambe. Okay, so we'll take these last two questions. The client refused to be tested for HIV, but how did you know she was HIV positive? And then the next question is, I would like to know the outcome in terms of general condition, because it seems the patient had more issues than a sexually transmitted infection. Back to you, Mr. Francis.
Come again, Doc?
So the client had refused to be tested for HIV, but how did you know she was HIV positive? And then the next question is, I would like to know the outcome of the patient, because it seems that she had more than just a sexually transmitted infection.
Thank you very much for those questions. The client had refused to test for HIV. So what the clinician did, they collected the blood sample for full blood count, and at the same time, they conducted an HIV test in the lab. So that's where our number 3 question is coming from, to say how best can we manage this client who has refused to test for HIV, but through the DCT, the HIV was tested and then confirmed positive. So in short here is the patient doesn't know that she was tested for HIV. So how do you break that news to her? So that's how we came about to know our HIV status. Thank you. The second question. No,
you can go ahead with the second question.
Okay. The second question of the outcome of the client. It's a pity that we didn't get the BP profile for this client later on, the days that followed, so that we would have presented them together. But from what the attending clinician has reported to us is that the BP is being, the hypertension is being managed fairly well. Though the figures, I do not have the figures currently with me. Thank you.
Okay, and one
but
last
we
question.
endeavor to get the full details. Yes,
thank you, thank you. And one last question, was the client screened for other opportunistic infections?
I think on that one, I'll say I'm not very sure with it, because the case was just brought to us today, so we haven't found out about that. But we endeavor to go around the case, carry out the other investigations, and even check the current status of the patient, so that we can have a full outcome of what is pertaining with the patient currently. Thank you.
All right, thank you so much, Yeta District Hospital, for that wonderful presentation. At this point of time, I'd like to welcome our expert panel. On our panel, we have Dr. Mundia, Mwitumwa, and Dr. Chitalu, Chanda. These are our local infectious disease physicians. You're both welcome. I'd like to call upon you for your expert recommendations and your comments for this topic of the day. Dr. Chanda, Dr. Mwitumwa, over to you.
Good afternoon. This is Dr. Mwitumwa. Thank you for the presentation. I'd like to recognize the presence of Dr. Ngalamika. I thank you again for the presentation that you have given to the team. The case is quite complex, I think, keeping in mind that HIV test was done discreetly, and now we have to figure out ways on how to convince this client to accept doing the HIV test, which is very important for her. She presented with a headache. So looking at what we have, this headache could mean anything. It could be any optimistic infection. So we are looking at either crypto, we're looking at possibility of neurosyphilis. Of course, we don't have much information as to when the likelihood of possible infection. I think there's a lot of information we should have gotten out in the history. It could just be the hypertension also. So we really need to think through about treatment. In a setting where we are not able to do certain investigations, and if we are concerned she's presenting with any neurological symptoms, I would consider actually treating this client as a case of neurosyphilis. Then, of course, we need to screen for cryptococcal meningitis. We have to do a serum CRAG. we also need to rule out any possibilities of a TB. She presented with a fever, so I hope the team did screen for TB. So urine lamp would be very important in this patient. That would be my my uptake on this patient. Thank you.
Thank you so much, Dr. Mwitumwa. I'd like to call upon Dr. Chanda. Dr. Duncan Chanda is an infectious disease specialist. Dr. Chanda, your comments, please. Thank you. So I'd like to call upon Dr. Ngalamika for your final comments on the case and on the topic in general.
Okay. Yeah. Okay. Yeah. With regards to the case, I think Dr. Mwitumwa has raised a number of issues. I think without extensively investigating this patient, it will be very difficult to make concrete conclusions. So if there was a health facility who could even send samples, they run them for you so that you have this comprehensive information, because I mean, you need to do the kidney function test. Patient was swelling, facial swelling, and a lot of other things that were going on. I suppose the ceftriaxone that was given was for the fever and something else. Yeah, I think the patient had fever. I suppose it wasn't for gonorrhea, because gonorrhea we give 250 milligrams IM stat. So I mean, I'm assuming that you were suspecting sepsis or something else. That's why you gave that. So I think workup is very important. In the absence of signs and symptoms, so screening, yes, there are certain, you need to know which STIs to screen for and when to do so. So syphilis, there's no harm in screening every now and then. Other STIs, there's no need to screen, like herpes and warts and all this, there's no need, but there are some STIs, syphilis, hepatitis, HIV, you need to screen even when the patient has no symptoms. So in terms of partner notification, I think there are so many methods that have been used before. I don't do that kind of research, but of course we try to apply it in the clinical context. I think sometimes people use cards or they inform someone else. There are so many different methods. So if one method hasn't worked, you can try to look at other methods in which you can get the information out to the partner, because it's very important that will save a life. So you need to look at the different ways of communication, the different public health and sexual approach in terms of communicating with potential partners, or I mean, partners to people who present and have been diagnosed with STIs. The last one, I'll leave it to Dr. Duncan to address that. The third one, if he's still on the platform. Otherwise, in terms of the other STIs, is what we've looked at. Those are the common ones. They are not the only ones. If you can test. If you cannot, treat according, there's a syndromic management flow charts which are available for, for level 1 or even below facilities that may not have the laboratory support. So those you can use the flow chart. If this is there, is this there, or is this there not? Then at the end of the day, you come to a conclusion, okay, I'll give this drug.
Thank you, Dr. Ngalamika. A very difficult question. Thank you very much, Dr. Ngalamika, for the presentation, and thank you, Dr. Mundia, for your input. I think this is a very difficult case. First, we have all agreed the investigations were not complete, but also we have to bear in mind where our colleagues are sitting. Clearly, they've got very limited resources to try and wake up their patients. But like you have pointed out, there are some things which will still remain hanging, and we need to further investigate this patient, particularly in terms of renal function and cardiac function. Having said that, in terms of DCT, I think the attending clinician was correct to do the HIV test. But the approach, actually, I'm afraid here it sounds like they went in the very old system where you literally start asking the patient whether it's, they will be interested in an HIV test and ABCD. When you go in the provider inserted testing, counseling testing, you actually inform the patient you're going to do this, unless they have got a very, very strong position to say no, they cannot do the test. In this case, looks like we need counselors to sit down with the patient, tell them they need to undergo HIV test and actually do the test at that point. Like Dr. Mundia pointed out, this patient actually looks more like she's a potentially she has got some opportunistic infections such as crypto. It could be TB meningitis. So that's the pathway we should be going on. We really have to talk to this patient. The other possibility is this patient knows their status, especially that you mentioned something to do with where they're staying, their occupation, and how they came in. She probably knows her status, and so she needs to be engaged actively so that we reveal her status. By the way, the viral load should have been done as well at baseline for this patient. It might help you answer one or two things. If, for instance, if she's completely suppressed, you might think that this patient actually has been on treatment for some time. They should be aware of getting to this patient, and then we make sure that she agrees to an HIV test, and then we actually review her status. She remains a risk to herself in terms of her medical condition, and then to society in terms of transmitting the virus to other people. I hope she's still in touch with the healthcare service, and she will need aggressive counseling to try and get over her issues. I wasn't very clear. I can't remember whether she's married and whether she has children. I think those are issues which can also come into play. Clearly, you're not going to just reach out and review her STI status to other potential partners. The law on that in Zambia is quite weak. Dr. Ngalamika, I tend to be corrected. I know in the US, such cases, you are really obliged to report to other sexual partners after a certain period. Is it 7 days or something when the client is refusing, which is completely different. So in some states in the US, you can actually reach out to the other sexual partners if that index client actually refuses to reveal to other partners. So I think we still have a lot of work to do with this with this patient. I think, honestly speaking, we should remain in contact, reach out to Dr. Ngalamika and Dr. Mundia. This is their daily space, and let us see what we can do for this client. Thank you very much.
So much, Dr. Chanda. We'll take one or two last burning questions before we end the session. You can unmute your mics or raise your hands or post in the chat box. Any last few questions? Okay.
Check for some comments in the chat. There's some comments in the chat box.
Okay, so we have a question. If the patient agreed to be tested for HIV, are you going to do a new test, which is retesting, or are you going to disclose the status based on the first result you got for HIV? I think that is to our presenter from YETA. And then the next question is, where can we get access to syndromic flowchart, and is it available for download or for printing? So for Yeta District Hospital, your question is, are you going to retest the patient? Or are you going to disclose the status based on the first results you got? Then Dr. Mwitumwa, Dr. Chanda, or Dr. Ngalamika, are these syndromic management charts available for printing or downloading?
I believe they are. It's just they will be updated soon, since the guideline is going to be updated. So they usually are printed out and distributed to especially the facilities that do not have lab support, because they are meant for those facilities. So once the guideline is out, but I think there are old ones that were printed from previously, and the guideline has recently been reviewed. There's a new guideline coming up, and I think they will be made available after that. Otherwise, one can reach out to the Ministry of Health for them through the district office.
Okay. Sumanyambe, if you're able to talk now, I know you've had challenges unmuting yourself. You had a question you wanted clarity on the drug history. The drug history being presented, was it prior to the patient being diagnosed, or that was the management at the point of diagnosis? This is again for Yeta District Hospital. Mr. Francis, would you like to take that question, please?
Yes, Doc. Yes, the drug history was at the point of interaction with the client when she came to the hospital. That's when this treatment was commenced.
Okay, thank you. I hope we've answered your question, Sumonyambe. And then I think one last question, what ART regime was this patient on, given that she had an HB of 7 grams per deciliter? Mr. Francis.
What's the question again, Doc?
What ART regime was this patient on, given that she had an HB of 7?
Thank you very much for that question. Unfortunately, the client is not on any ART currently, because she declined the HIV testing, and the one which was done was. Thank you.
All right, thank you so much, Mr. Francis from Yeta. Special thanks to our panel of experts, Dr. Mundia Mwitumwa, Dr. Duncan Chanda, and our didactic presenter, Dr. Ngalamika, for joining us today. We really appreciate your time. I think we've learned quite a lot. A special thank you to our IT team, Mr. Kote and Mr. Chatonda, and a special thank you to our coordination team, Madam Metambuyu. So on behalf of the Ministry of Health ECHO program, I'd like to thank the network for joining us today. And I'd like to wish you a great day ahead. Thank you.
Thank you very much, Doc.